Welcome to the deep dive. We're about to crack open some truly fundamental and quite complex material from the sources you've shared. Today, we're really plunging into Chapter 85.
That's right. And the focus here isn't just, getting the gist.
No, definitely not. The goal is to extract the absolute core knowledge, the kind that helps you really master this information. Think depth and nuance, like the experts in the field.
We're building that mental framework piece by piece. So you understand not just the facts about renal cell carcinoma, RCC, as we'll probably call it a lot, but why those facts matter.
How they connect, how the thinking has evolved.
Exactly.
So our mission today, thoroughly explore the key aspects of RCC laid out in this chapter. We're covering, well, everything from how common it is, the potential causes, how it behaves, how it's detected.
How we stage it to get a handle on prognosis, and critically, how treatment strategies have really advanced, particularly based on our growing knowledge of its biology.
And the source material also gives us a little bit on related areas. We'll touch on high-grade neuroendocrine carcinomas briefly at the start. They pop up right at the beginning of the file.
Yeah, got to acknowledge those. They're different, but important.
And then towards the end, we'll provide a bit of broader context on other urinary tract cancers, drawing from the intro to the next chapter in the source.
Just to place RCC in the bigger picture.
Exactly. But make no mistake, the main event, the deep dive for mastery today, is all about renal cell carcinoma as detailed in Chapter 85.
Okay, let's get into it. Where should we start? How about the landscape?
Good idea, setting the scene. So, renal cell carcinomas, RCCs, they are the most common type of malignant tumor, starting right in the kidney tissue itself.
And most common is really putting it mildly. The source says they account for a, massive 90 to 95% of all malignant kidney neoplasms.
Wow, 95%. That really hammers home how central RCC is when we talk about kidney cancer.
It's the vast majority.
Yeah.
And it helps to contrast that with the other 5–10%. What are those mainly?
Those are primarily transitional cell carcinomas, or you might hear them called urothelial carcinomas.
Right. And they start somewhere different, don't they?
Yeah, unlike RCC from the main kidney substance, these start in the lining of the renal pelvis. That's sort of the internal funnel that collects urine before it heads down the ureter.
Different origin, often different behavior, different treatment pathways. Good distinction to make up front.
So while kidney cancer is the umbrella term, most of the time, especially when we get into the treatments and the science, we're really talking about RCC.
Okay. Now, you mentioned the source file actually kicks off before Chapter 85 proper with a bit on high-grade neuroendocrine carcinomas, or NETs.
Yeah, they're distinct from RCC, but included, so worth a quick mention before we dive deep into RCC.
Absolutely. So these high-grade NETs, they're relatively uncommon. But the critical thing is they are biologically very different from the more common, often slower-growing, well-differentiated neuroendocrine tumors.
And that difference means they behave differently.
Dramatically so. These high-grade ones pursue a really aggressive clinical course. That's the key takeaway.
And historically, how are these aggressive NETs treated with systemic therapy?
Well, the traditional chemotherapy approach for advanced high-grade NETs closely mirrored what's used for small cell lung cancer, which is another aggressive neuroendocrine type.
Okay, so similar thinking. What drug specifically?
Typically combination chemo. Usually cisplatin or carboplatin, those are platinum agents paired with etoposide. That was the preferred first-line approach for a long time.
Platinum plus etoposide. Got it.
Yeah.
Now, the source highlights something really important for guiding that chemo decision, the Ki-67 proliferative index. What exactly is that?
Right, Ki-67. It's basically a marker, a measure of how fast the tumor cells are dividing. A high Ki-67 index means rapid proliferation, which is, a hallmark of aggressive cancers.
And studies looked at this marker in high-grade NETs.
Yes, a large retrospective study, 252 patients, specifically looked at how Ki-67 correlated with the effectiveness of that platinum-based chemo. And the findings were pretty clear.
What did they find?
They found that the platinum chemo worked significantly better in patients whose Ki-67 index was 55% or higher.
Okay, a threshold effect. What was the response rate in that high Ki-67 group?
In those patients, Ki-67 euro, 55%, the overall tumor response rate was 42%, which in this context is a pretty meaningful response.
42%, okay. And what about when the Ki-67 was lower, below 55%?
A stark contrast. The response rate dropped way down to just 15%.
15%, wow, big difference.
Huge difference. It really highlights how Ki-67 can be a practical tool to help figure out Who's most likely to benefit from that specific platinum adipocyte approach in high-grade NETs?
That's a great example of a biomarker, even if retrospective, guiding therapy. What about newer treatments? Immune checkpoint inhibitors? Any role there?
Yeah, the source notes that similar again to small cell lung cancer, these immune checkpoint inhibitors do show some activity in high-grade NETs. They haven't done much in the well-differentiated slower NETs, but there are promising early results in the high-grade ones.
Was there a specific trial mentioned?
Yes, a phase 2 trial, though small, 19 patients. It looked at the combination of ipilimumab and nivolumab.
Two checkpoint inhibitors targeting different pathways, CTLA-4 and PD-1.
Right, and that combination showed an overall tumor response rate of 42%.
42% again. Same as the high Ki-67 chemo group, but with immunotherapy. Interesting.
It is interesting. Suggests immunotherapy, maybe combination immunotherapy could be another important option for these tough tumors. It's definitely an area of active research.
Okay, so that covers the high-grade NETs mentioned at the start of the file. Important, aggressive, but distinct.
Precisely. Now, let's pivot. Full focus on the main event, Chapter 85, Renal Cell Carcinoma. Let's start with the big picture epidemiology, risk factors. Who gets RCC?
Okay, incidence trends in the U.S. The source talks about a rise over 3 decades, then a sort of plateau around 64,000 cases a year between, 2012 and 2018?
Yeah, but then it picked up again more recently. The latest estimates mentioned are now up to about 76,000 cases annually in the U.S.
So it's climbing again, and sadly, that translates to deaths too.
Unfortunately, yes. Around 14,000 deaths per year in the U.S. from kidney and renal pelvis cancers.
How does that rank RCC overall in the U.S. cancer picture?
It's the 8th most common cancer overall. If you look at gender, it's 6th in males, 8th in females.
And there's a definite gender split.
Clear male predominance. The source states a 2-to-1 male-to-female ratio.
What about age? Is this a disease of the young, or?
No, it's quite uncommon under age 45. The incidence really ramps up with age, typically peaking between 55 and 75. So more of a middle-aged and older adult cancer.
Okay. The source lists several risk factors linked to RCC. What are the main ones?
Well, some common culprits are there. Cigarette smoking, for one.
Not surprising.
No. Obesity is also listed as a significant risk factor, and hypertension, high blood pressure.
Those are pretty widespread conditions. Any risks more specific to the kidneys themselves?
Yes, the source specifically mentions an increased risk for people with polycystic kidney disease, especially if it's complicated by chronic renal failure.
Makes sense. Pre-existing serious kidney trouble raising the risk of kidney cancer.
Exactly.
Okay, that gives us a good sense of who's affected and some risk factors. Now let's get into the real core of it, the pathology and genetics. The source really stresses that RCC isn't just one thing, is it?
Absolutely critical point. If you want to master this, you have to understand RCC is a diverse group of tumors. They look different under the microscope, they have different genetic drivers, and crucially, they behave differently clinically. Heterogeneity is key.
So let's break down the major types, the categories based on pathology. What does the source say about prevalence?
Okay, referencing Table 85-2 and the text.
Yeah.
The big one, the most common by far, is clear cell carcinoma. That's about 70% of all cases.
70%.
And importantly, it's the type found in over 80% of cases that have already metastasized, spread elsewhere, so it's dominant, especially in advanced disease.
What's next most common?
Papillary tumors. They make up about 10 to 15%. These can sometimes be bilateral, meaning in both kidneys, and multifocal, multiple spots in one kidney.
Okay.
Chromophobe tumors. Less common, maybe 5% or less. These tend to have a more indolent or slower clinical course generally.
Then there are some rarer but important ones.
Yes. Renal medullary carcinoma, very rare, less than 1%, but known for being extremely aggressive and linked to sickle cell trait. Translocation carcinoma, maybe less than 5%. This is actually the main type seen in children, though it's rare in adults. And then you have a bucket of other less common variants and some tumors that are just hard to classify called unclassified with variable behavior.
So clear cell is definitely the main player we need to understand, especially for genetics and treatment. Let's dive into the genetics of clear cell RCC. Where do these cells originate?
They're thought to arise from the epithelial cells lining the proximal tubules in the kidney. Those are the workhorse cells doing a lot of the reabsorption of fluids and salts.
And what's considered the earliest, almost universal genetic hit in clear cell RCC?
The source points to the loss of chromosome 3p. The short arm of chromosome 3 is just gone.
Losing a whole chunk of chromosome. What does that mean functionally?
It leads to what's called loss of heterozygosity for the genes on 3p. You started with 2 copies, one from each parent, now you're down to 1. and several key tumor suppressor genes live on 3P. The big ones mentioned are VHL, PBRM1, BAP1, and SATD2.
So losing one copy is the first step. How is the function fully lost?
Usually there's a second event, maybe mutation, maybe something else that inactivates the remaining copy of the gene on the other chromosome 3. That two-hit process knocks out the gene's function completely.
Let's focus on VHL, the von Hippel-Lindau gene. The source really emphasizes this one, especially its link to treatment. What does the VHL protein normally do?
Right, VHL is crucial. It encodes a tumor suppressor protein. Its main job in a healthy cell is to regulate how the cell responds to oxygen levels. It does this by targeting proteins called hypoxia-inducible factors, or HIFs.
HIFs. Okay, what does VHL do to them?
When there's enough oxygen around, VHL binds to HIF proteins and tags them for destruction using a process called ubiquitination. It essentially tells the cell's garbage disposal system to get rid of HIF.
So VHL keeps HIF levels low when oxygen is normal. What happens in clear cell RCC where VHL is often inactivated?
When VHL is knocked out due to that 3P loss plus a second hit, it can't tag HIF for destruction anymore. So HIF proteins build up inside the cell constantly, even if there's plenty of oxygen.
Ah, so the cell is basically tricked into thinking it's always starved for oxygen?
Exactly, and high HIF levels switch on a whole bunch of genes that help cells survive in low oxygen. Critically, this includes genes that ramp up angiogenesis, the growth of new blood vessels, especially vascular endothelial growth factor, VEGF.
VEGF. That's the key link, isn't it?
That's the link. VHL inactivation leads to this massive, inappropriate overproduction of VEGF. And VEGF drives the formation of blood vessels that feed the tumor, letting it grow and potentially spread.
And here's the crucial part for treatment. This dependence on VEGF creates a vulnerability.
Precisely. That's the aha moment. Because clear cell RCC is so reliant on this constant VEGF signaling due to VHL loss, it makes the tumor highly susceptible to anti-angiogenesis therapies, drugs designed specifically to block VEGF or its receptors.
Wow. So understanding that one genetic pathway, VHL to HIF to VEGF, directly led to a whole class of effective drugs. That's huge.
It revolutionized treatment. It took RCC from being largely untreatable with systemic therapy to having effective targeted options.
That connection is so important to grasp. The source also mentions large-scale sequencing efforts. What else have they shown us?
These big sequencing projects have been really illuminating. They found other commonly mutated genes in clear cell RCC beyond VHL, like PBRM1, BAP1, CDTD on 3P, plus others elsewhere. But maybe more importantly, they've revealed recurring patterns of genetic changes.
Patterns, meaning specific combinations of mutations.
Yeah, or specific chromosomal gains or losses that tend to occur together. And what's fascinating is that these distinct genomic patterns often correlate with distinct clinical behaviors.
So different genetic signatures might predict how aggressive the tumor will be or where it might spread.
Exactly that. It's moving us towards a more refined understanding beyond just labeling it clear cell. Some clear cell tumors are inherently more aggressive than others based on their underlying genomic makeup.
Can you give an example from the source, a specific pattern linked to behavior?
The source highlights the early loss of chromosome 9P. When that happens, it seems to confer a high risk for the tumor spreading early metastatic dissemination, and it correlates strongly with poorer survival for the patient.
So identifying that 9P loss could be a powerful prognostic marker that really shows the value beyond just VHL.
Definitely.
Now let's quickly touch on the genetics of the other, less common RCC subtypes from Table 85 Tastrue. What drives the papillary type?
Papillary RCC, the second most common type. There are different subtypes, but a key genetic driver can be activating mutations in the MET oncogene, or gaining extra copies of chromosome 7 where MET lives.
And is that actionable, like VHL VEGF?
Yes. Just like VHL loss makes clear cell vulnerable to VEGF inhibitors, these MET alterations make papillary RCC susceptible to targeted MET inhibitors. Another great example of genetics guiding therapy. Other alterations seen in papillary include extra copies of chromosomes 7 and 17, loss of 9P, and changes in FH and CDKN2A.
Okay, what about chromophobe RCC?
Chromophobe tumors, they seem to be driven partly by changes in mitochondrial gene function. Genetically, they often show marked aneuploidy, weird numbers of chromosomes, with frequent losses of whole chromosomes like 1, 2, 6, 10, 13, 17, and 21. Common mutations are found in TP53, PTN, and the TERT promoter.
And renal medullary carcinoma, the very aggressive one.
Associated with sickle cell trait, yes.
Mm.
Key alterations include gains in AQ, losses of 22q, specific translocations involving 22q, and alterations in the SMRCB1 gene deletions, mutations, fusions plus mutations in CT22.
Lastly, the MITF translocation type.
These can sometimes look like clear cell or papillary. The defining feature is a translocation, a swapping of genetic material involving the MITF family genes. Specifically, XP11.2 translocations creating TFE3 gene fusions, or T611 translocations creating TFEB gene fusions. Identifying these fusions is key to diagnosis.
That's a whirlwind tour of the diverse genetics, really hammers home the heterogeneity point. The source also mentions familial forms, inherited syndromes.
Right, most RCC is sporadic, just happens. But there are inherited syndromes that significantly increase risk. Table 85-1 lays them out.
Let's hit the main ones. VHL syndrome is probably the most famous.
Definitely. Von Hippel-Lindau syndrome, autosomal dominant, caused by inherited mutations in the VHL gene on 3p. These folks have a huge lifetime risk of clear cell RCC, maybe up to 70%.
Wow. And it causes other tumors too.
Yes, it's a multi-system disorder. Retinal hemangiomas, brain spinal cord hemangioblastomas, pheochromocytomas, pancreatic cysts, and neuroendocrine tumors. A whole spectrum.
Okay, so VHL syndrome, high risk of clear cell RCC. What about hereditary papillary RCC?
That's linked to inherited mutations in the MET gene on chromosome 7. As the name suggests, it predisposes to papillary RCC, often the type by subtype, and frequently these tumors are bilateral and multifocal.
And HLRCC, the one with leiomyomas.
Hereditary leiomyomatosis and renal cell carcinoma syndrome, caused by mutations in the FH gene. This was associated with a particularly aggressive type of non-type I papillary RCC, plus skin leiomyomas and uterine fibroids or even sarcomas.
Birt-Hogg-Dubé syndrome.
Yep, BHD. Mutations in the FLCN gene. This syndrome is linked mainly to chromophobe RCC and also benign oncocytomas. Clinically, patients often have distinct skin findings called fibrofolliculomas and lung cysts.
Tuberous sclerosis complex, it's on the list too.
TSC, caused by mutations in TSC1 or TSC2. Primarily associated with benign kidney tumors called angiomyolipomas, but can rarely lead to actual RCC of various types, plus all the other TSC features in brain, skin, heart, etc.
And one more, BAP1 tumor predisposition syndrome.
Right. Inherited mutations in the BAP1 gene, also on 3p. Similar to VHL, it increases the risk of clear cell RCC. It's also linked to other cancers like certain skin tumors, atypical Spitz, uveal melanoma, mesothelioma, and others.
That covers the key familial syndromes, important for genetic counseling and recognizing patterns. Let's switch now to how RCC actually shows up, the clinical presentation. What was the classic triad?
Ah, yes, the classic triad. Historically, it was hematuria, blood in urine, flank or abdominal pain, and a palpable mass feeling the tumor.
Sounds like fairly advanced disease if you can feel it. The source says this triad is much less common now.
Much less common. And the reason is simple. Imaging.
CT scans, MRIs.
Exactly. With the widespread use of cross-sectional imaging for all sorts of reasons, kidney tumors are now most often found incidentally. Someone gets a scan for something totally unrelated, and bam, there's a mass on the kidney.
Stumbled upon, basically. What's the impact of finding them incidentally like this?
It's been huge, and mostly positive. Incidental tumors tend to be smaller and at an earlier stage. Catching them early dramatically improves survival rates. It's also allowed for more nephron-sparing surgery, partial nephrectomy preserving kidney function.
Makes total sense. Earlier detection, better outcomes, less invasive surgery. Besides that now less common triad, what other symptoms might lead to an RCC diagnosis?
The source lists things like unexplained fever, weight loss, anemia, or sometimes a varicocele in men.
And then there are those perineoplastic syndromes, the weird systemic effects caused by the tumor, not its physical presence. What are some examples linked to RCC?
Yeah, RCC is kind of famous for these. The source lists erythrocytosis, too many red blood cells, hypercalcemia, high calcium, non-metastatic hepatic dysfunction liver tests go wonky without liver mets, sometimes called Stauffer's syndrome, an acquired dysfibrinogenemia, clotting issue.
How common are these at diagnosis?
Some are pretty rare. Erythrocytosis is only seen in about 3% at presentation. Anemia, though, is more common and often suggests more advanced disease.
This brings up that historical nickname. The source mentions the internist's tumor. Why was it called that?
Because back before ubiquitous imaging, patients didn't usually show up with that classic triad. They'd often present to their internist with one of these weird perineoplastic syndromes, fever, weight loss, high calcium. The internist would do a workup for that problem and eventually stumble upon the underlying kidney tumor.
Really highlights how much imaging has changed things.
Completely.
So, a mass is suspected or found. What's the standard diagnostic workup according to the source?
Typically starts with a contrast-enhanced CT scan of the abdomen and pelvis. That gives detailed pictures. Also a chest x-ray to look for obvious lung spread, and a urine analysis.
What if the chest x-ray looks suspicious?
Then you get a chest CT for a much more detailed look at the lungs, since that's a common spot for metastases.
When does MRI come into play?
MRI is particularly good for a couple of things. Evaluating the inferior vena cava if you suspect the tumor is growing into that big vein, or if there's a tumor thrombus. And it's used when CT contrast dye is a no-go, usually because of poor kidney function.
The source states a really important clinical principle about solid kidney masses.
Yes, any solid renal mass found on imaging should be considered malignant until proven otherwise. Assume it's cancer unless you have definitive proof it's not. That drives the next steps.
And if that initial workup shows no distant metastases, what's the general approach?
Surgery is indicated. Even if the tumor is invading the renal vein or the vena cava locally, if there's no distant spread, surgery is usually the recommendation.
That's key. Local vein invasion doesn't automatically rule out curative intent surgery. What about managing small renal tumors, especially the common clear cell type?
For small tumors, particularly clear cell, the immediate risk of spread might be lower. So in some cases, surgery could potentially be delayed. But a critical first step is getting a definitive diagnosis. Usually with a needle biopsy of the mass, you need to confirm the histology. Is it definitely clear cell RCC? Is it benign? Is it something else?
And if biopsy confirms it's a small, low-risk RCC?
Then radiographic surveillance, watching it closely with repeat scans, might be an option for a period before proceeding with surgery. But biopsy first is key for that decision.
Makes sense. Biopsy to know what you're dealing with. What else could a solid kidney mass be besides RCC? What's the differential diagnosis?
Well, it could be a complex cyst, though usually distinguishable from solid. Benign tumors like adenomas, angiomyolipomas, oncocytomas, inflammatory things like pyelonephritis or an abscess, other kidney cancers like transitional cell from the pelvis, sarcoma, lymphoma, Wilms's tumor, or even metastases to the kidney from another cancer.
But RCCs is the most likely.
By far, it's the most common cause of a solid renal mass. Keep it top of the list.
And if RCC does spread, where does it typically metastasize?
Common sites mentioned are lungs, lymph nodes, regional or distant, liver, bone, and brain. And remember, the source notes the clinical course can be unpredictable, sometimes slow, sometimes changing unexpectedly.
Adds to the challenge. Okay, let's move to staging and prognosis. How do we define the extent of the disease?
We use the standard AJCC staging system, the American Joint Committee on Cancer. It's based on TNM, tumor, nodes, metastasis. Figure 8501 in the source details it.
Let's break down TNM. What did the T stages mean for the primary tumor?
T describes tumor size and local invasion.
Can't assess.
Tumor is 7 centimeters, just in the kidney. T1A is half 4 centimeter, T1B is 4 to 7 centimeters.
Tumor 7 centimeters, still just in the kidney. T2A is 7 to A 10 centimeters, T2B is 10 centimeters.
Tumor grows into major veins or surrounding fat tissue, but not beyond Gerota's fascia, the capsule around the kidney. T3A invades renal vein, sinus fat, or collecting system, T3B. Tumor thrombus in vena cava below the diaphragm, T3C. Tumor thrombus in vena cava above the diaphragm or invading the cava wall.
Tumor invades beyond Gerota's fascia into adjacent organs or the ipsilateral adrenal gland.
That T3 category with the vein involvement is quite detailed. Important distinctions there. What about N for nodes?
N is for regional lymph nodes.
Can't assess nodes.
No regional node mets.
Metastasis in regional lymph nodes, like those around the renal artery vein.
And M for metastasis.
M is for distant spread.
No distant metastasis.
Distant metastasis present lungs, bone, liver, brain, non-regional lymph nodes, etc.
How do these T, N, and M components combine into overall stages I through IV?
Okay, roughly.
T1, 0, M0, small, confined, no nodes, no mets.
T2, N0, N0, large, but still confined, no nodes, no mets.
Is either T1 or T2 with N1 nodes, but M0. Or it's T3, vein local invasion, with any N0 or N1, but still M0. So more extensive locally or node positive, but no distant spread.
Is either T4 invading beyond fascia, any N, N0, or it's any T, any N with M1 distant mets. Basically very advanced local invasion or any distant spread.
Got it. Clear breakdown. What stage do most people present with these days?
Thanks to that incidental detection, the majority, about 65%, present with stage 1 or 2 localized disease. Around 15–20% have stage 3, and another 15–20% unfortunately already have stage 4 metastatic disease at diagnosis.
What's the overall 5-year survival rate across all stages combined?
Current overall 5-year survival is about 75%, but that average hides huge variation by stage. Early stage is much better than late stage. And for those with metastatic disease, stage 4, predicting prognosis is really important. That's where risk models come in.
Which model does the source highlight for metastatic RCC?
The International Metastatic RCC Database Consortium model, or IMDC model, it's widely used.
What factors does the IMDC model look at?
It uses 6 factors that correlate with worse survival. 1. Poor performance status, how well the patient can function. 2. Low hemoglobin anemia. 3. High serum calcium. 4. High neutrophil count. 5. High platelet count. 6. Less than 1 year from diagnosis to needing systemic treatment.
So, common clinical and lab values. How does survival correlate with the number of these risk factors? The source mentions data for patients on first-line angiogenesis inhibitors.
Yeah, the correlation is really striking. Patients with 0 risk factors, favorable risk, had a median survival of around 43 months. 1 or 2 risk factors, intermediate risk, had a median survival of about 22.5 months. And those with 3 to 6 risk factors, poor risk, had a median survival of only 8 months.
Wow, 8 months versus 43 months. That IMDC model really separates out different prognostic groups. Huge implications for counseling and potentially trial design.
Absolutely.
Okay, let's pivot to treatment strategies now, starting with localized disease stages 1, 2, and some 3. What's the main approach?
For localized RCC, where the goal is cure, the standard management is surgery, either radical nephrectomy or partial nephrectomy.
Describe radical nephrectomy again.
That's removing the entire kidney, the surrounding gerotous fascia, often the adrenal gland on the same side, and any, obviously, abnormal lymph nodes all in one block.
How is it done? Open surgery?
Can be open, but increasingly done laparoscopically or robotically, which are less invasive.
Do they always take out the regional lymph nodes, even if they look normal?
That's actually a bit controversial, according to the source. A routine systematic lymph node dissection, a template lymphadenectomy, isn't universally done if the nodes look okay pre-op and during surgery.
What if it's stage 3 with tumor in the renal vein or vena cava, but no M1 disease? Surgery still on.
Yes. As we said, if there are no distant mets, invasion into the veins doesn't preclude resection. The surgery is more complex, involving a thrombectomy to remove the tumor thrombus from the vein, but it's potentially curative.
Now, what about the nephron-sparing options? Partial nephrectomy.
Partial nephrectomy, just removing the tumor plus a margin, is increasingly common and preferred when feasible, depending on tumor size and location. Again, can be open, laparoscopic, or robotic.
Who is partial nephrectomy especially important for?
Crucial for patients with only one kidney, tumors in both kidneys, or pre-existing kidney disease. You want to save every bit of functioning kidney possible in those cases.
Can you do it even if the patient has 2 perfectly good kidneys?
Yes. The source says partial nephrectomy can be done electively for smaller masses, even with normal kidney function in the other kidney. The thinking has shifted towards preserving kidney function whenever safely possible.
And what's the big advantage of partial versus radical when it's an option?
Long-term kidney function. Removing a whole kidney, radical, increases the risk of developing chronic kidney disease later on, which itself carries risks for cardiovascular problems. Partial nephrectomy lessens that long-term hit to kidney function.
Makes sense. Okay, surgery is done for localized disease. What about adjuvant therapy drugs after surgery to prevent recurrence?
Big area of study. Lots of trials have looked at giving adjuvant cytokines, targeted agents like TKIs, after nephrectomy for localized RCC.
And the results?
Largely negative, according to the source. Despite the effort, these adjuvant systemic therapies haven't consistently shown a benefit in preventing recurrence or improving survival.
So the standard after surgery for localized RCC is?
Active surveillance. Just monitoring the patient with scans and checkups to catch any recurrence early if it happens. No routine post-op drug therapy.
Okay, that covers localized treatment. Now, the tougher situation, metastatic disease, stage 4, what's the role of surgery here?
It's more limited. Surgery usually isn't curative once the cancer is spread widely.
But the source mentions metastasectomy and cytoreductive nephrectomy.
Right. Metastasectomy is removing isolated metastatic spots. If a patient only has one or maybe a few small areas of spread, surgically removing them might be considered in select cases, potentially alongside systemic therapy. Cytoreductive nephrectomy is removing the primary kidney tumor, even though metastases are present elsewhere.
Why remove the kidney tumor if it's already spread?
It's not usually for cure. The source mentions it can be done sometimes to relieve major symptoms from the primary tumor, like severe pain or bleeding. The role of doing it routinely just to potentially improve survival with systemic therapy is more debated now than it used to be, especially with modern effective drugs.
What about radiation for metastatic RCC?
Mainly palliative. Used to relieve symptoms from specific metastatic sites, commonly bone metastases causing pain, or brain metastases causing neurological issues. Can use various techniques like external beam or more focused stereotactic radiation.
So surgery and radiation have specific, often palliative roles. What's the real mainstay of treatment for metastatic RCC?
Systemic therapy. Drug treatments that go everywhere.
When do you start systemic therapy? Immediately.
Not always. The timing needs thought. If a patient has metastatic disease but feels fine, and the cancer seems to be growing slowly on scans, you might actually watch them for a bit.
Why delay?
To avoid treatment side effects if the cancer isn't causing immediate problems. The source suggests documenting progression before starting therapy in some asymptomatic, indolent cases. But if there are symptoms or faster growth, then yes, you'd start treatment.
Now, the source makes a key historical point about treating metastatic RCC.
Yes, it was famously refractory to traditional cytotoxic chemotherapy. Chemo just didn't work well for this cancer type, which was a huge problem for decades.
So what changed things? How did outcomes improve so dramatically?
It all came back to understanding the biology, those pathways like VHL, HIF, VEGF we talked about. That knowledge led to the development of molecularly targeted agents and then immunotherapies. These have transformed outcomes. The goal now is often long-term disease control, keeping the cancer in check for as long as possible, even if cure isn't achievable for most with metastatic disease.
What are the main classes of targeted agents mentioned?
Big ones are the tyrosine kinase inhibitors, TKIs, that mainly hit VEGF signaling. Examples are sunitinib, pazopanib, axitinib, cabozantinib. Then there are MPOR inhibitors like everolimus, sometimes used with lenvatinib, which is another TKI.
How did treatment evolve as these drugs came out?
Initially, it was often sequential monotherapy. Start with one oral TKI. If it stopped working, switch to another TKI or an MTOR inhibitor. Pivotal clinical trials figured out the best sequences and which drugs worked best, first line versus second line, summarized in Table 85.3.
Then came immunotherapy. Where did that fit in?
Immunotherapies, harnessing the patient's immune system, came next and were another massive leap. They were first tested after the targeted agents were already standard.
What was a key early immunotherapy breakthrough for patients who had already had a TKI?
The source highlights the trial comparing nivolumab, a PD-1 inhibitor, against everolimus, the MTOR inhibitor, in patients whose RCC progressed after TKI therapy. Nivolumab showed better overall survival.
So nivolumab became the new standard second-line choice.
Exactly. Better survival than the previous standard in that setting.
But the biggest recent shift has been in first-line treatment for metastatic RCC, using immunotherapy combinations, right?
Absolutely. This has really changed the standard of care for most newly diagnosed metastatic clear cell RCC patients. Combination regimens have shown superior efficacy compared to using a single TKI upfront.
The source names two specific combinations that beat the old standard, sunitinib, in frontline trials. What were they?
First was nivolumab, PD-1 inhibitor, plus pilimumab, CTLA-4 inhibitor. This immuno combo was superior to sunitinib, particularly in intermediate and poor-risk patients based on the IMDC model. Impressively, it led to complete radiographic responses, no detectable cancer on scans in over 10% of patients.
Over 10% complete response. That's remarkable in metastatic solid tumors. What was the other key combination?
That was pembrolizumab, another PD-1 inhibitor, combined with exitinib, a VEGF TKI. This immuno-TKI combo was superior to sunitinib alone in all comers, meaning across favorable, intermediate, and poor risk groups. It showed high response rates across the board.
What were the common threads? How did these combinations outperform the single TKI?
The source emphasizes that responses with both combinations tended to be durable, long-lasting. They significantly improved progression-free survival, time without the cancer growing, and, most importantly, led to longer overall survival compared to sunitinib.
So combination therapy, either two immunotherapies or immunotherapy plus a TKI, is now the standard first-line approach for most patients.
That's the current paradigm, yes. And research is ongoing, looking at new combinations, different sequences, trying to push outcomes even further.
With all these effective but different options, biomarkers seem crucial. Ways to predict who benefits from which combo. What's the status there?
That's the million-dollar question, isn't it? Biomarkers are urgently needed to personalize therapy, predict response, predict toxicity. Lots of candidates have been studied, but As the source clearly states, none have been validated for routine clinical use yet in metastatic RCC.
Still, that's really striking. We have these targeted and immune drugs. We understand some of the pathways, but we can't reliably test a tumor and say, you need combo A, not combo B.
Not yet. Not reliably for individual selection. Treatment choice is still often based on broader factors like the IMDC risk group, trial data for that group, patient comorbidities, and potential side effect profiles. It highlights a major unmet need.
Despite that biomarker challenge, the overall impact on survival has been huge.
Huge. The source projects that overall survival for patients starting therapy for metastatic RCC has basically tripled over the last 15-20 years.
Tripled. Wow.
Directly attributable to these drug developments, the TKIs, MTR inhibitors, and especially the immunotherapies and combinations.
An amazing success story driven by science. Okay, let's broaden out slightly. Global picture and related cancers. Worldwide RCC numbers.
Over 400,000 diagnoses annually, and sadly, over 175,000 deaths globally each year from malignant kidney tumors.
Where does it rank globally?
10th most common cancer in men, 15th in women worldwide.
Are there geographic differences?
Yes, higher rates in developed countries, North America, Europe, Australia, NZ, Uruguay, low rates generally in Southeast Asia and Africa, and globally, incidence has also been rising over recent decades.
What about mortality trends worldwide? Are they improving everywhere?
Unfortunately, no. While mortality has stabilized in places like the US and Europe, it hasn't in many less developed countries.
And a likely reason for that disparity?
Access to care. Specifically, access to these newer, effective, but often expensive targeted and immunotherapies. The best guidelines don't help if the treatments aren't available or affordable.
A stark reminder of global health inequities. Now, to place RCC in context, the source file had intro material for the next chapter on bladder and urinary tract cancer.
Right. It helps show where kidney cancer fits. Cancers of the urinary tract, bladder, renal pelvis, ureter, urethra are collectively the second most common group of GU cancers. Kidney cancer is the most common within that group.
How common is bladder cancer itself in the U.S.?
Sixth most common cancer diagnosis overall, around 81,400 cases and nearly 18,000 deaths annually in the U.S.
And the other urinary tract sites, like renal pelvis, ureter, the urothelial ones?
Harder to get exact numbers as they're often lumped with kidney cancer stats, but the source estimates maybe another 20,000 cases and 5,000 deaths annually from these non-bladder urothelial cancers.
Different risk factors for these bladder epithelial cancers compared to RCC.
Smoking is a huge one in the U.S. But in developing countries, contaminated water arsenic or infections like schistosomiasis are major drivers.
Genetics involved too.
Yes, inheritable germline risk factors are found in up to maybe 1/7 of patients with these cancers.
And progress is being made there too, similar to RCC.
Definitely. The intro mentions an accelerated understanding of the molecular basis of urothelial cancer, leading to more trials and FDA approvals of new drugs since around 2016. Similar story of science driving progress.
Good context. It shows this molecularly driven approach is impacting related cancers too.
It's the direction oncology is moving across the board.
Okay, I think we've really done a comprehensive deep dive into Chapter 85 and the related pieces. We covered the basics, what RCC is, who gets it, why.
We went deep into the genetics, that crucial heterogeneity, the VHL pathway, and how understanding the molecules is key to understanding behavior and finding treatments.
We walked through detection, that shift to incidental findings diagnosis, staging using TNM, and prognosis with the IMDC model.
And we traced that dramatic evolution in treatment, from surgery for localized disease to the revolution in metastatic care, moving past failed chemo to effective targeted agents and game-changing immunotherapies and combinations.
Which, as you said, have tripled survival, even with the ongoing challenge of finding those predictive biomarkers. You should now have a really solid, expert-level framework for understanding renal cell carcinoma based on these sources.
And thinking about that progress, especially the combination therapies, alongside that biomarker gap, it leads to a really interesting question for the future.
So here's a final provocative thought for you. Given all these effective combination therapies and the urgent need for personalization, how does research move beyond just finding more effective combinations to actually predicting which specific combination is truly optimal for an individual patient based on their unique tumor biology, finally cracking that biomarker code?
Because the next big leap isn't just more drugs, it's using the tools we have and the ones coming with genuine precision for each person.
Something to keep thinking about, keep exploring these concepts.